Good afternoon, and welcome to the Editor's Podcast for the Journal of the Academy of Nutrition and Dietetics. I am Dr. Linda Snetselaar, Editor-in-Chief of the journal. And with me today, I have Dr. Jaime Gahche, who is an epidemiologist at the National Institutes of Health in the Office of Director, Office of Dietary Supplements, the Division of Coordination, Planning, and Strategic Initiatives. And her manuscript is titled Malnutrition Risk Among the 2022 National Survey of Older Americans Act Program, a cross-sectional study. And this manuscript will be appearing in one of our upcoming issues of the journal. So welcome today, Dr. Gahche.
Thank you. I'm very happy to be here.
So I'll start with my first question. What is the purpose of the 2022 National Survey of Older Americans Act program?
Okay, so the 2022 National Survey of Older Americans Act program, or NSOAP, as I will be referring to it, is a nationally representative sample of programs on aging, like congregate and home-delivered meals that Congress funded by Title III of the Older Americans Act. The NSOAP is really an essential tool for understanding how well federally funded aging services are working across the country. And these programs are authorized again under the Older Americans Act, which was passed back in 1965 and has grown really into the backbone of community-based services for older adults, especially those at highest social and economic need. So the idea of these services is really to help older adults age with dignity and independence, ideally in their own homes and communities rather than institutional settings. And so this survey has been carried out by the Administration on Aging. The Administration on Aging sits in the Administration for Community Living, ACL. It's under the Department of Health and Human Services, but I do want to mention, as part of Secretary Kennedy's vision to streamline HHS to better serve Americans, critical programs in ACL that support older adults and people with disabilities will be integrated into other HHS agencies, including the Administration for Children and Families, the Assistant Secretary for Planning and Evaluation, and the Centers for Medicare and Medicaid Services. But this, again, we wanted to mention this reorganization will not impact Medicare and Medicaid services. So as I mentioned, the Administration on Aging carries out this NSOAP survey. And what makes this particular survey so valuable, again, is that it collects national level data directly from the older adults who receive Older American Act services programs. The survey includes people who are using home-delivered meals, often known as Meals on Wheels in the past, as well as those attending congregate meal sites, typically community centers or senior centers that serve meals. But the survey goes beyond nutrition programs. It also includes recipients of case management services, transportation assistance, homemaker services, which help with things like cleaning or shopping and other forms of support that allow, again, older adults to live safely and healthfully in their homes. And then also I wanted to mention the survey doesn't just ask about whether people received Older American Act services. It really digs into the experiences. It asks about satisfaction, perceived quality, like participants' functional limitations, nutritional status, and even how Older Americans Act services may be affecting their health or ability to live independently. So it really provides a very rich picture of the lives of older adults in these programs. And then again, from a policy and program standpoint, the results are incredibly important. They help the federal government, states, and local agencies figure out, what's working well, what needs to be improved. If, for instance, survey data shows that a high percentage of people receiving home-delivered meals are still reporting food insecurity or isolation, that's a prompt to dig deeper and maybe adjust how these services are delivered or provide more wraparound support. So the survey really helps ensure that these programs remain evidence-informed, equitable, and aligned with real-world needs of older Americans.
I was wondering too, your study design is cross-sectional, and I wondered if you would tell me how you use that particular type of study design in your investigation, in your research.
So yes, the NSOAP uses a cross-sectional study design, which means it collects data at a single point in time from a sample of older adults across the country who are currently receiving services funded again by the Older Americans Act. So it's like taking a snapshot of their experiences, health, and needs at that moment. I wanted to also mention the survey includes multiple service categories. So it's collecting data from those receiving home delivered meals, congregate meals, case management, homemaker services, and transportation services. So it goes beyond just the nutrition services. And then for each service, how they sample is they take a national representative sample of participants. And the survey design uses two stages. In the first stage, slightly less than half of the nation's area agencies on aging, called AAAs, are systematically selected to participate in the survey. And just a quick note, AAAs are local agencies across the country that coordinate and deliver services to older adults in their communities. So getting back to the sampling, after these AAAs provide their client list, the second stage incorporates a random selection of clients per service from each of these selected AAAs. So for the survey in 2022, all the data was collected through structured interviews by phone with questions covering a wide range of topics: demographics, functional status, nutritional risk, service satisfaction, perceived impact on independence and well-being. And then new in 2022, the survey also added the questions from the Malnutrition Screening Tool, or MST. And these questions are just a couple of questions, and they're based on unintended weight loss and eating poorly due to a loss of appetite. So this is a way for us to assess malnutrition risk in a standardized way across all the different programs. So since it's cross-sectional, the survey doesn't track changes over time in the same individual, but it does allow researchers and policymakers to assess the overall state of service delivery and client outcomes at the national level. And this design is particularly useful for evaluating program reach and identifying unmet needs. And again, it can't show causality, but it provides a powerful snapshot that informs everything from program improvement to policy development.
Why do you think malnutrition risk is so important as we look at older Americans?
So malnutrition risk in older adults is one of those issues that really can be easy to overlook, but has major consequences for health, functionality, quality of life, and even healthcare costs. As people age, they become more vulnerable to malnutrition for a whole host of reasons. Some of those are physiological, like reduced appetite, changes in taste and smell, arthritis that limits their ability to shop or cook for themselves, or chronic illnesses that can really impact nutrient absorption and utilization. But then there's others that are more social factors, things like living or eating meals alone, not having reliable transportation to get groceries, having limited income to buy foods. So malnutrition in older adults, again, it's not always obvious. It's not just about weight loss or not getting enough calories. It can also be about protein deficiency, inadequate hydration, lacking key vitamins and minerals, and the effects can be really serious. So malnutrition is associated with weakened immune function, delayed wound healing, increased risk of falls, frailty, which is a really big one, hospital readmissions, and even more higher mortality rates. It's also a major contributor to functional decline, meaning that someone could go from living independently to needing help with almost all daily tasks just because their nutrition hasn't been adequately addressed. So malnutrition risk screening is done really to select out people who likely turn out to be malnourished upon further assessment. So malnutrition risk can be easily assessed by self-report in common settings where a dietitian or other healthcare professional may not be present. Those who are then found to be at malnutrition risk can be then prioritized for further assessment in a clinical setting to make sure they really are malnourished and to get at the root cause for what is causing the problem. Then what can be done is we can prevent or treat the problem. That's why it's so important that we screen for and address malnutrition early, especially in community settings, because many older adults at risk of malnutrition are still living at home and may not be in regular contact with the healthcare system. This is where programs like home delivered meals and congregate meals come in. They provide a consistent source of not only food, but social contact, health screenings, referrals to needed services, and nutrition education. So even just having a daily meal delivered can serve as a check-in point where someone can spot red flags. So when we talk about the significance of malnutrition risk, we're talking about something that affects the entire aging trajectory also. So preventing or mitigating that risk can really help to keep older adults healthier, more independent, and more engaged in their communities for longer.
Thank you. So many important concepts related to malnutrition risk in our older populations. And then, what would you say are 3 takeaway messages from your manuscript?
So the first big one is, we definitely saw a segment of older adults using these services that are at malnutrition risk. So approximately 1/5 of older American Act program participants were at malnutrition risk in 2022 across all the programs, so the nutrition ones and the non-nutrition ones. And then specifically, so total malnutrition risk prevalence was 19.5%. But then by program type, it was 19.4% for those in home delivered meals, 16.7% in congregate meals, and then for the non-nutrition programs, it was 22.5% in homemaker, 22.1% for case management, and 21.4% in transportation. We didn't find a statistically significant differences between programs. Second, the Older Americans Act home delivered meal programs can make a difference. So we found that participants receiving home delivered meals for 2 to 5 years were 72% less likely to be at malnutrition risk compared with those receiving home delivered meals for just under 6 months. And we found this in our fully adjusted models. Third, all Older American Act participants really should be regularly screened for malnutrition risk. So really just going back to that first point, in 2022, both nutrition and Older Americans Act non-nutrition programs were serving many individuals at malnutrition risk, suggesting that all Older American Act participants really should be regularly screened for malnutrition risk. Because again, early malnutrition detection that is followed by appropriate, timely intervention is ethically and medically appropriate to support the health and quality of life of older adults. So malnutrition risk should trigger person-centered and efficient referrals to meals and other social and economic support services. And then identifying and treating malnutrition risk early also helps to reduce the costs associated with that delayed diagnosis and treatment.
Incredibly important messages coming from your research. And then finally, how might a practicing RDN use your research in a clinical setting?
So there's a few different ways of practicing RDN, especially ones working with older adults, might use the findings from the 2022 National Survey of Older Americans Act program in a clinical, but also in a community setting. First, the research provides insight into the scope and scale of malnutrition risk among older adults living in our communities who are already connected to aging services. That's useful because these are often people who might not otherwise be on a clinician's radar. So if the data showed that a significant number of older adults receiving home delivered meals are still at risk of malnutrition, that's a call to action for RDNs to look more closely at how those services are structured and where additional interventions might be needed. Second, it also identifies the Older Americans Act programs as prime partners for clinicians to establish bidirectional referral networks to address malnutrition risk and provide assistance that supports healthy aging in the community. So in fact, the Academy's evidence-based guidelines for malnutrition in older adults recommends home delivered and congregate meals to reduce the incidence of malnutrition. The data in this article helps RDNs justify the need for nutritional services and support within broader healthcare and public health systems. A lot of what dietitians do is evidence-based, but also under-resourced. So being able to point to national data that show, for instance, that nutrition services are associated with improved self-reported health or reduced hospital visits really helps build the case for sustainable funding and integration of nutrition into multidisciplinary care. RDN can also encourage primary care providers to routinely screen older patients for malnutrition risk and make timely referrals to dietitians. So, really strengthening the connection between clinical care and community-based nutrition support. And then finally, RDNs can use this information to improve screening and assessment practices. For example, they might advocate for incorporating validated malnutrition screening tools into routine visits at congregate meal sites or during home visits, and then develop processes for follow-up nutrition assessments for those at risk. And just to note, so there's many states that really do have, they implement the determine checklist at a home delivered meals and congregate meal sites. So they're already asking about some issues like polypharmacy that may be part of the problem, but asking more about just these two simple questions on malnutrition risk, using questions like, just unintended recent weight loss and eating poorly due to a lack of appetite. It really gives more clues as to who may need further assessment so that it is possible to prioritize those likely to be malnourished for care. Or they might collaborate with case managers or home care teams to ensure that nutrition is a part of every care plan. And then I just want to mention this research really supports advocacy and systems change. Whether an RDN is working in clinical care, community health, or policy, again, this data can be used to inform grant proposals, develop quality improvement initiatives, or push for better training of providers who regularly interact with older adults. So in short, the research is not just a snapshot. It's really a practical tool that can help dietitians make better decisions, advocate for their patients, and ultimately improve outcomes for older adults across the spectrum of care.
Dr. Gahche, thank you so very much for the detail that you've presented in all of the questions and responses to my questions. And I think that the novelty and timely relevance of this particular topic is going to be something that is very interesting to Academy membership. And just thank you again for responding to my questions. And I appreciate your time in participating in this interview.
Thank you so much. I really enjoyed participating.